So today's presentation is titled Choosing and Implementing the Assessment and Interventions for Perinatal Depression Best Practice Guideline. So it is my pleasure to introduce you to our speaker for today. So our speaker today is Cassandra Forjay. She's the Indigenous Mental Health and Addictions Worker at Chigamik Community Health Centre. She is also the BPSO lead here at her organization, and she works with a supportive team to assist in the planning, implementation, and evaluation of their best practice guidelines. Cassandra completed her social service worker diploma at Fleming College, and she recently graduated from the Bachelor of Social Work program at Lakehead University. If you can't find Cassandra in her office, she's likely out exploring the wilderness with her family and dog. She is looking forward to our discussion today.
So hi there, everyone. My name is Cassandra Forjay, so thanks for that wonderful introduction. And I do want to just acknowledge I am using some Bluetooth headphones, and they are actually already beeping at me saying that they're going to die on me, unfortunately. So if that does happen, I will continue to be able to do the presentation. I just unfortunately won't be able to hear you. So yeah, feel free to pop some questions into the chat box. And at any point, if you cannot hear me anymore, please just let me know as well. But I will just get started. So like I said, my name is Cassandra Forjay, and I am the BPSO project lead here at Chigamik Community Health Centre. I am also the mental health and addictions worker working with Indigenous and non-Indigenous individuals and families. So I'm very happy to be here talking about the assessment and interventions for perinatal depression best practice guideline. So I also wanted to continue with the land acknowledgement just for where I'm based and working from today. So I would like to acknowledge that the land which we are gathered on today is the traditional territory of the Anishinaabe Nation. I would also like to acknowledge the enduring presence of the Indigenous people of this region, specifically the Chippewa Tree, Council First Nations, Compromise of the Bosley First Nation, the Chippewas of Rama, and the Chippewas of Georgina Island. I would also like to acknowledge the Moose Deer First Nations, the Wata Mohawks, and the Georgian Bay and Moon River Métis councils in this region. It should also be noted that the Wendat and the Haudenosaunee nations have also walked on this territory over time. Okay, so I just wanted to share a little bit about Chigamik Community Health Centre and discuss a little bit of what we have to offer. So Chigamik Community Health Centre is a nonprofit, community-governed primary healthcare organization. So as a CHC, we provide a combination of primary care, health promotion programs, and community development initiatives that are culturally relevant, holistic, as well as available in English and French. So using interprofessional teams of health providers, our programs and services are considered and planned from a holistic perspective, connecting physical, emotional, mental, and spiritual well-being in an interconnected circle. So Chigamik team, or our Chigamik team, includes nurse practitioners, physicians, health promoters, mental health and addiction counselors, dietitians, registered nurses, community health workers, administrators and management, among lots of other staff members. So together we play a central role in our clients' and communities' healing journey in a respectful, nurturing, and inclusive environment. So Chigamik is currently in the pre-designation period of the Indigenous focused BPSO project. So during this time, we have taken on 2 BPGs, the Perinatal Depression Guideline and the new Indigenous Smoking Cessation Guideline for Indigenous women and families in the perinatal period. Okay, so I did just want to cover a little bit of an agenda as to what I'm going to be speaking about today. So I'm going to kind of talk a little bit about why we chose this BPG, our gap analysis, engaging champions, planning stage, implementation strategies, evaluation and monitoring of our BPG, and Indigenous ways of knowing. And then of course, at the end, we can have time for some discussion and questions. So why did we choose this BPG? So after looking over all of our services and programs, we found a gap in service basically, and Chigamik was offering a valid screening tool for mothers experiencing depression. However, our screening process was different for many of our practitioners. Therefore, we wanted to improve our screening rates for mothers in care to ensure they didn't slip through the cracks. So by choosing this BPG, it allowed us to enhance our partnership with the Midland Midwives, who we share a large percentage of our clients with. I believe actually 90% of our pregnant women were getting into perinatal care from the midwives and then returning to our care during their postpartum period. So a large portion of our clients coming in that are pregnant do go to their care first and then come back to us. So Chigamik wanted to ensure women were getting screened for postpartum depression as often as possible, as we know many of the postpartum visits were surrounded around the baby rather than the mom. So this is something we wanted to change or improve. And then finally, Chigamik was able to recently hire an Indigenous perinatal mental health worker who was also able to support the discussions and planning process in connection to this BPG. So that's some of the reasons why we actually chose this BPG specifically. And then next, I just want to touch on the gap analysis. So this is kind of what after we chose our BPG, we then went and did the gap analysis to find out the gaps that we weren't kind of being successful in, but also to look at our successes and different things like that. So yeah, after choosing our BPG, our next step was conduct this gap analysis with our steering committee or working group. So having representatives from each area in the organization that would be connected to this BPG. So for example, we had midwives, doulas, nurses, and management involved during our gap analysis exercise. So during this process, we allowed for 2 hours to focus strictly on our gap analysis to ensure we had time to have an in-depth conversation on each of the recommendations. So during the gap analysis, you basically go through each recommendation and ask if you've either fully met, partially met, or not met this as an organization. So while we're going through some of the recommendations, we found that some didn't pertain to our organization. So for example, there was a recommendation that talked about incorporating education and theory to introduce to new nurses in school. And we found that this was out of our scope of practice. So you may actually run into that as well while going through the gap analysis. So in total for this specific BPG, we went through 15 different recommendations and then decided on the top 3 to begin working on. So by doing this exercise, we were able to see where our organization was being successful and of course where we had to improve. So during this exercise of the gap analysis, it basically just sparked really helpful conversation moving forward for the planning and implementation stage. Okay, so the next kind of step that we did as an organization was trying to recruit some of our champions. So you can see here is a picture of some of our champions that attended a training in Toronto, actually. And so yeah, recruiting champions is a really crucial step while integrating any BPG. Champions can either be managers, frontline staff members, or community members. Champions are people that are quite passionate in improving quality of care while working with best practices. They help share knowledge, plan for practice change, come up with solutions or strategies, and advocate for positive change within the organization. So basically, the more champions, the better. So Chigamik currently has champions from the midwives, management, nurses, counselors, and program facilitators. And some of the techniques we kind of used for recruiting champions was to provide presentations at staff meetings by discussing the requirements for becoming a champion. We invited champions through email, prepared a sign-up sheet, and started to include BPSO in job descriptions for new staff members. So they kind of knew that this was a requirement of joining our Chigamik team. Okay, and then once we kind of had our steering committee or working groups along with some champions, we then moved into our planning stage of our 3 recommendations that we wanted to implement. Yeah, so a tool that really helped us was to develop a flow chart starting at the very beginning when the client walks in with different a recommendation that we choose. We kind of decided to do a flow chart. And then basically it just helped us walk through step by step until we found some practical areas for change or improvement. So it can also be very helpful to read the recommendation section in full, as sometimes the RNAO already provides an algorithm or helpful tips on how to move forward through the recommendation that you're trying to implement. And our organization decided to work towards setting smaller goals than changing our entire pre-existing process. So sometimes a small change can have, a large positive impact, and that you don't have to change anything drastic within your process if things are already working well. And one of my biggest tips is if you have a small number of staff to work on recommendations, is to kind of work on either one recommendation at a time or break it into smaller working groups with each working group taking on a certain recommendation. Okay, so after that planning stage, we of course wanted to move into implementation now that we had an idea of kind of the certain areas we wanted to target or improve in. And after coming up with a variety of strategies for each recommendation, we decided that it's time to definitely trial it out and put it into practice. So something we found helpful was to have a mini trial with a few providers that use it in their everyday practice to gain valuable feedback from them. Once we trialed it out for a couple of months with regular check-ins, we decided to share the new practice with the entire team by having conversations at all staff meetings or one-to-one with staff members that wanted to have a more open conversation. So of course, at the beginning of any new change, there will always be some hesitancies. So it can be important to allow the time for questions or a time to connect. So I did want to provide a little example of what we actually changed. So our new process for screening postpartum women. So yeah, here we decided to choose recommendation 1.1 for one of our 3 recommendations to implement. So this one was just to routinely screen for risk of perinatal depression using a valid tool as a part of prenatal and postpartum care. So this was actually the steps that I decided to break down for staff that were going to start this new change and implement it into their practice. So we decided as an organization that step 1, when booking a 2, 4, or 6 month well baby visit, was to also schedule a postnatal visit for the mother, kind of coinciding with the start of the well baby visit for the infant. So basically, if the well baby visit started at 9 a.m. and our well baby visits are booked for an hour, we would also double book the mom at the same time, allowing 15 minutes at the beginning of their appointment to have those conversations with mom. The next thing was to schedule of the postnatal with well baby. So this was just, this language was used here to remind practitioners that we wanted to schedule them with the well baby, as before this, it was just directed at the well baby. So yeah, this basically, when they decided to schedule this in using this bolded kind of scheduling name, I guess is what it's called. We have different names for scheduling and different appointments. And so every time they hit this scheduling type, it will result in a link to complete the Edinburgh screening tool, which is our valid tool for postpartum depression, automatically being sent out to mother to complete prior to the next well baby visit. And is actually sent out a day before of their visit coming out. So this way the mom actually got to complete the screening tool in the comfort of their home. Because before we were actually giving them paper copies out in the waiting room, which sometimes wasn't working out best if they had a toddler or their newborn. So we thought sending it out ahead of time would be best for it to be completed prior coming into the session. And then we also said to please provide this information to your clients moving forward so they know to expect this link in their email or messages. So just giving them a heads up that this is going to be coming their way to fill out at home. Since this is kind of a new process that we're doing. So definitely to include the clients in this new process. And then we had 3 more steps here to follow. So once the mother completes the Edinburgh form, it actually gets automatically uploaded to their chart with their responses. And we have an example in one of our chart numbers here. It's just a fake patient, but it was a good example to show our staff members as to what exactly it was going to look like. But yeah, that was another really big plus for us, was that the screening tool directly gets put into their chart so that when practitioners are going in, they can, 5 minutes before their appointment, go have a look at their scores and kind of figure out what the next steps. So we go here to number 5, and that's exactly what I just mentioned there. So providers will now be able to view the results in the mother's chart before or during their appointment to see their score and severity. And then this is when you can take the next steps in their care plan. So for example, if low risk, you just simply move on to other discussions. Maybe it's about how mom's healing, how mom's doing with this big change in the family, having a newborn, and things like that. If it's a medium risk, then we can discuss Mama Tribe, which is a peer-led support group with other moms, or they can discuss some counseling if that's something that they like to proceed with. And then of course, if it's high risk, you of course discuss Mama Tribe again, counseling, and maybe perhaps some pharmaceutical interventions if there's any kind of anxiety or depression medication that they'd like to maybe trial out as well. And then the last one here, number 6, is if the client does not fill out the Edinburgh ahead of time, you can ask them to fill it out during the session together, following the link in their email, and kind of doing that all together within that visit, since we now have 15 minutes designated towards the mom at this time. So that's our new process that we're actually trialing right now, and we're going to be revisiting this at our next clinical meeting to see how the practitioners are liking this, if there's any issues with anything, just to allow some time for feedback. Okay, just trying to hit, oh, there we go. Oh. Okay, so yeah, after now that we're implementing this process, we also want to keep in mind evaluation is also equally as important. So yeah, when it comes to evaluation, it can be very useful to ask yourself how your organization already gathers data, if it's something new that you're doing for evaluation. Asking yourself, is it best to gather our data in a qualitative way or a quantitative way? For this BPG, we were used a lot of different encodes and bookings, as I mentioned. So we were actually able to gather data in a quantitative way using our data support analysis here at Chigamik to pull monthly reports to keep track of increases and decreases. The RNAO can also provide you with indicators to help track or to assist you with data collection. And then we were also gaining valuable feedback from our staff members and about our new process, and if they were finding it helpful again. So a little bit of qualitative data as well. And then evaluation is a crucial step while implementing a BPG, as you want to ensure that the change you made is making a difference for the people you are serving in the community. So some BPGs also have order sets that the RNAO provides to assist in data collection with the EMR, making tracking more manageable. And currently there's no order sets for this specific guideline, so we did have to think about some other evaluation processes moving forward. Okay, and I did want to include just Indigenous ways of knowing, since Chigamik, we do definitely serve a large portion of Indigenous people within our community. So, and as mentioned earlier, Chigamik is part of the Indigenous focused BPSO working group. And basically we're working with many different organizations across Ontario. And together we collaborate to honor Indigenous ways and practices through holistic approaches to care. Chigamik serves a large portion of First Nation and Métis populations within the North Simcoe region. So Chigamik has designated staff positions that meet the needs of our Indigenous community members, such as the Traditional Healing Program, Connection to Elders, the First Nations Métis and Inuit Foot Care Program. We have a recently hired Indigenous perinatal mental health worker, Indigenous specific nurse practitioners, an Indigenous massage program, an Indigenous doula collective, and we also have a lot of different cultural ceremonies and workshops and programs throughout the year. So yeah, just when working with Indigenous community members, we talk about what holistic care means to them, as not all Indigenous members practice the same culture or traditions. Chigamik is currently offering many services directly to our local reserves, as services on the reserves are kind of sparse. For example, our closest reserve is Christian Island, which is a 30-minute car ride from town, as well as a 20-minute ferry ride to access good quality care. So it can be quite tough to access care and services. And then the ferry also has its own schedule. So people coming off reserve can expect a full day in town pretty much just to gain some services or access to a doctor. So by offering services right on the reserve, it can break down barriers and enhance relationships between the service provider and the clients. And something that is equally important is building strong relationships with the people that we're serving. This can be done by hosting or attending events such as ceremonies, workshops, or celebrations within the community itself. And then finally, it's important to keep up with cultural sensitivity trainings to ensure that you have cultural awareness and gain valuable teachings or lessons, just basically on how to better support Indigenous families and individuals. And then sometimes just asking questions can be the best way to kind of learn from the people that we're serving. And then here we have some pictures of our healers. So we have Pam Tremblay, she's a Métis healer here. Jacob Gone, that's holding the feather in the orange shirt. He is our medicine man. And then this is a community member that is doing a smudge here at one of our ceremonies. So yeah, I mean, that's kind of the presentation and how Chigamik has kind of went through the process of implementing this specific BPG. Of course, we've had tons of support with coaching calls from the RNAO, and then of course our knowledge exchange meetings with our cohort as a team. So that's been really helpful in managing how to take on a new BPG. So yeah, I just wanted to thank you, Say Merci and Miigwech, for taking the time out of your day to come to this presentation. And I hope you kind of learned some different techniques about how you can implement a BPG within your organization. And so I do want to allow this maybe for discussion or questions and things like that. So if you have any questions, then feel free to ask away.
Thank you, and Miigwech, Cassandra, for such a brilliant presentation, choosing and implementing the assessment interventions for the perinatal depression best practice guideline. So I just want to comment, I really loved how you showed us the interprofessional stakeholder engagement in your planning, implementation, and recruitment of champions. And thank you as well for sharing how Chigamik incorporates Indigenous ways of knowing within your organization, how you provide tailored holistic care to the people that you serve. So at this time, let's see, we will take some questions from the audience. So just a reminder, if you have any questions, please type them in the chat box. And I'm just going to review the chat box right now. I have a comment from Grace saying that you had an excellent presentation. And a question I have a question from Nicole. So Nicole's asking, how have these changes been received by the community? Has there been any pushback from the community introducing something that is not in their innate culture?
Yeah, so definitely when it comes to, I mean, this specific BPG, we really focused on screening and then definitely developing a care plan afterwards once we decide how severe things may be within the home. Definitely when we're talking again with that client, it's really ensuring that we're looking at a holistic approach where, you know, not all Indigenous people practice Indigenous ways, right? So I think that's something really to be respectful of and just providing as many different options as possible when engaging any one of our clients, right? So, you know, there's 10 different options, say we include all 10 of those options for anyone that comes through the door. So whether that's the one a connection to an elder to have any questions or concerns or a discussion with them, you know, connecting with their doctor to ensure that they're also on the same path as the counselor, for example. So really just making sure we're including all staff members in this approach, and then most importantly, the client in deciding how they want to continue moving forward with this care. So yeah, I mean, so far it's been received really well by the community. I think they really appreciate the fact that they're getting screened or just being asked these questions around mental health and postpartum depression, because I do find that sometimes when you have your baby, you're just kind of, okay, now here's your baby, you go off to the world and you're at home now. And then a lot of the meetings afterwards are focused around baby, right? How's baby progressing? Are there different challenges with baby? So I think that this process just really allows that dedicated time to speak with mom and to see really how mom and family's adjusting to these certain situations. So I think they really just appreciate that 15 minutes of time that's dedicated towards them and, you know, resolving any issues or concerns that they may have during that time.
Thank you, Cassandra. I just have another follow-up question. So good points. And is there a more common point of prevalence for perinatal that practitioners should look out for? Or are you finding that these interventions are required long-term postpartum? And common point of prevalence for perinatal depression.
Yeah, so I'll just read that quickly again. So is there a more common point of prevalence for perinatal that practitioners should look out for? So as far as, yeah, I mean, screening is just one point of, you know, we have to ask the screening tool to be able to learn more about how they're coping, but definitely to one of our actual other recommendations, providing education to staff around what to look out for signs and symptoms of postpartum depression. We have a really strong connection with our midwives, which they look after them while they're pregnant and then 6 weeks following, and then they come back into our care. So it's really not letting that fall through the cracks when they're coming back to our care. You know, following up with them, making the appointment. Sometimes I know that the doctor will go ahead and say, okay, make an appointment for a follow-up visit. And sometimes, you know, life just gets busy and that doesn't happen. So making sure that we take it as the staff member to give them a call and say, hey, just, you know, checking in and wondering if they want to make a follow-up visit. So yeah, I think just, you know, just really making sure that we have good, strong education around what postpartum depression looks like / mood disorders, because there's tons of different mood disorders that are out there in relation to postpartum depression. So yeah, just providing that ongoing knowledge to our staff members. And then as well as in Mama Tribe, we try to provide education or at least a safe space for women to come to and talk about different issues every Wednesday. So that's a drop-in group. And I hope that answered your question.
Thank you, Cassandra. I was going to say that I really like the idea of how you schedule the postnatal baby visit along with a visit with the mother as well. So that gives some dedicated time for the practitioner to speak with the mother.
Yeah. I find, and I think it's nice too, because we do block an hour for well baby visits. So the first 30 minutes is usually with their nurse, like a nurse that does the more, you know, weighing of the baby and things like that. And then the second half of that 30 minutes is actually with their doctor. So it's nice how there's quite a bit of staff that's involved in their well baby visit, just to ensure that, you know, everything's running smoothly and that mom has best quality care. And if she really does screen high for postpartum depression, that there is a Indigenous mental health or perinatal mental health worker here that they can just quickly get referred to within the organization instead of finding it elsewhere. We do know that there's not a lot of perinatal support when it comes to counseling within our area, and I'm sure that's similar to a variety of different areas in Ontario or Canada. So we're really fortunate to be able to have this specific funding for Indigenous women that are going through different mental health concerns and have someone to talk to.
Thank you, Cassandra. That's wonderful to hear. I did receive another question in the chat.
Okay.
And the question was that, which strategies did you find most helpful in implementing the best practice guideline?
Yeah, so I would say that just the planning is most important when implementing the practice. I find implementing it, of course, we want things to go smooth, and I guess it's just very much laying out what your organizations decide to move forward with. But I would say like the most important strategy is really just getting the right people involved that are going to be doing this as an everyday practice. So for us, I mean, we didn't get the entire organization involved as it's very hard to connect. And of course, we were trying to navigate this implementation through COVID. That was, another factor that made things a little bit tricky connecting with everyone. So I would say the biggest tip that I found most helpful was having working groups. They were small, very engaged working groups with the right people that were, this was everyday practice for them. So of course they wanted to improve this. So yeah, really, even working groups of 3 or 4, we did have management involved in those as well, just to further spread the word when it came to, engaging our doctors and physicians and things like that. But definitely small working groups with the right people involved really allowed us to push forward and really start to see change within our organization.
Cassandra, I'm hearing from you that you really got a lot of engagement with selecting the correct team as well. There's a lot of work with selecting the correct team. I also see that you had a lot of interprofessional engagement, and that's, from hearing from you, that was a key to your success in implementing the BPG.
Yeah, absolutely. Just making sure that we had lots of representation from different people, that this was going to be a part of their practice, right? So if they're going to be screening women, then it was most important to have them sitting at the table deciding what's going to work and what's not going to work. So that was a key helpful factor for sure.
Thank you. I do have another question in the chat from you. And the question is, out of all these steps, which one did you find the most challenging and why? Was it the planning? Was it the implementation? Was it the evaluation?
Yeah, so the trickiest stage, I guess, out of them I would have to say again, it's the planning stage, and just I think a large factor of that was COVID, the impacts that COVID had. I mean, a lot of people had to resort to going to do assessment center tasks, you know, testing, and they got pulled to a different direction that none of us could have ever prepared for, right? And then it's the burnout afterwards. So it's almost like, you know, hey, we gotta, you know, work on this still, but a lot of people weren't necessarily in the right mind frame to be also implementing a lot of change within the organization at a stressful time. So I would have like, yeah, just trying to connect with everyone virtually was a very hard thing to do. The only couple times I could connect with them was through email. So I think a lot of, you know, just trying to do the planning of, you know, what's really going to work here, when are we going to start our trial and things like that. It was just a lot of the fine details that were slow moving, I would say. So that's where I find, okay, I'm, you know, maybe it is best just to work within a smaller group rather than a large group, because we can start to really move forward in a good direction, right? So I think planning was a hard stage, but it's very much one of the most important stages. So just know that it's okay if things take time, right? And just to work on one thing at a time rather than trying to do all these recommendations, because it can get a little bit stressful at times. So just slow things down and one thing at a time.
Thank you for sharing that, Cassandra. Yes, it's really hard these days with the COVID-19 pandemic. Like, kind of often organizations have to pivot and be flexible, and when it comes to planning and implementation and other projects as well. And I'm hearing from you that you had to you had to adapt to working virtually and having smaller working groups.
Yeah, absolutely. Yeah, I think all of us can probably relate to the different changes that we had to move into during the pandemic. And, you know, luckily, I think there's been a little bit more, I don't want to say the word normalcy, but I think there's just a little bit more, we see our work routines coming back to what they were previously, which is nice.
And that's wonderful to hear. Hope everything will have some sense of normalcy soon, hopefully. Yes.
Yeah, for sure.
Thank you. I just gonna check in the chat if there's any other questions. So I have another question. And it was there other recommendations looked at, or only this one mentioned?
Yeah, so as far there's about like I'm not actually sure how many recommendations. Sorry, I read BPG for a second. So absolutely. So we looked in the gap analysis, we looked at about 15 different recommendations to take on, and I can actually share the three that we chose. So the first one was the screening one that I shared there. The second one was developing a care plan. So after we find out how severe they are within the results of the screening, was to then develop their care plan. And for us, that was looking at the different mama tribe, the counseling, or an elder, or all these different options, as many options as we could provide to establish their care plan. So that was our second recommendation we looked at. And then the third recommendation was education for staff on what postpartum depression looks like, or mood disorders within individuals. So yeah, we did implement 3 at a time, and I think it was like 3 out of 15. We did find that we were achieving, you know, some of them as well. And then, like I mentioned, some of the recommendations didn't necessarily pertain to our organization. But yeah, I think it was just mentioned that we could start off with 3 and try to get those achieved. And I think that was also just a part of our pre-designation offering that we were kind of doing, that it was RNAO kind of explained that we can take on 3 at this time. And then of course, once we are successful in doing that, it's all about sustainability moving forward. And then maybe if we'd like, we can take another one that's partially met and move it into our met area as well.
Thank you, Cassandra. I'm just going to check for so there's any other questions in the chat. If anybody's raised their hand. All right. So got a thank you. So, okay, all right, everybody. We've had such an engaging discussion today. And as we prepare to wrap up today's webinar, I would like to thank everyone today for taking the time out of your day to take part in this webinar today. So for those of you who are participating in this live webinar, you will soon receive a link to an online survey to evaluate today's presentation. After you have done this evaluation, you will receive your certificate of attendance. In addition, please let us know any suggested topics you would like us to work on. Again, thank you, Cassandra, for sharing your experiences with us and implementing this BPG. It was a pleasure to hear you speak today and talk about your organization's work.
Yes, thanks so much for having me. And again, yeah, thanks for everyone taking the time to join me on this discussion. And I hope it was valuable and something you can maybe introduce into your organization.
Thank you. And again, the question that this webinar will be recorded and uploaded to RNAO's website and YouTube page whenever you watch it. So thank you, everybody. And thank you, Cassandra. Again, thank you, everybody. Thank you so much, everyone, for joining us today. And please enjoy the rest of the day. Please know that this work is funded by the Government of Ontario.